Thanks, Lee. Hey, everybody. As Lee stated, my name is Ben Hampshire, and I'm a solutions architect here with the Select Group. And today, we'll talk about technologies in the healthcare space that involve electronic medical records and the strategic direction of healthcare institutions, both today and into the future. A little background about me. I've been in the healthcare IT world for over 10 years, both in the consulting and operational capacity. I've led multiple integrations of EMRs over the years, including being heavily involved in implementing a full revenue cycle suite of modules across multiple hospitals and practices. Over the years, I've encountered many changes in the healthcare landscape, which are in continual progression. This involves many different specialties and skills throughout. Outside of implementing EMRs, I've been able to work through multiple projects that involve data center migrations in the healthcare space, integration of new vendors with current applications, optimization of workflows, expansion of facilities, both in merger and acquisition of new facilities, and pandemic-related capacity management, and involvement in training and materials of those applications. I've held positions that vary from consultant to system analyst up to management and strategic levels. Hopefully, everyone will find some areas of potential growth and clarification throughout the presentation. Since we do have a fair amount of content to cover today, I'd ask that we please hold the questions until the end of the conversation. So please, as Lee stated, post the questions in the chat, and we should have time at the end to definitely get to all of them. So here's what we'll be covering today. Some of the complexities that are involved in the healthcare world, especially with integration points within and outside of electronic health records, and some common solutions used by most vendors in that space. We'll discuss what are electronic medical records and electronic health records. And since I know we have a broad range of knowledge in the healthcare space on the call, I wanted to run through a scenario that focuses on the intricacies involved with any changes to equipment or software throughout the full clinical and revenue cycle workflow. I think that will help everyone relate with the scenario and paint a full picture. Along with that, we'll continue through some quick history, focus on some top concerns and trends, and then lastly, we'll go through some large changes that healthcare organizations deal with. Over the next couple of slides, we're going to talk through some identifiable situations and concepts that we all deal with in the healthcare world, and also how all of these things together make a rather complex organization of disparate system information in the back end to get that information into the format that we're used to seeing in our patient portals that we use to look at our medical information. For example, as you can see here, there's a mobile app or web portal that most care systems have some form of. But even for end users, sometimes finding the information that you're looking for can be difficult. Let's say you want to hop on and pay a bill or review some lab results. Let's investigate all of the different aspects that have to come together to get that information there accurately. The electronic medical record systems play such an important role in this, along with interfaces and APIs in order to get this information from a bunch of different systems into one user-friendly format. Not only does this information need to be organized, but also the precision of that information is of the utmost importance. Incorrect diagnoses can result in delay of care, or worse yet, patient harm. And patient liability for billing is another area of concern that's a bit less impactful, but annoying nonetheless. There are so many different areas that this information is gathered, whether it be in a hospital stay with all of the tests and results involved there, an outpatient lab, a radiology exam, prescriptions, or just a checkup with your local provider. All of this information is integral in painting the full picture from the moment you step into a facility and get registered throughout your medical stay, and then also onto how your stay is coded and determination of what reimbursement rates the insurance companies will pay, and also how much you will have to pay out of pocket. So I know these diagrams are a bit involved, but I wanted to briefly illustrate how many moving parts can be engaged with EHRs overall. These diagrams only look at a portion of what really goes on behind the scenes with messages in the healthcare world. All of these integration points and messages need to have experts involved to ensure the accuracy of not only what these messages mean, what segments need to be sent in which message, but also where those messages need to be routed. Just at a glance, you can see that messages not only involve demographic information, but also orders, results, charges, medications, coding, and billing, just to name a few. So for an example, fundamentally, imaging and labs are in different systems, and pulling that information involves complex organization. And due to the risk of lives involved, not only do they have to be highly precise, but testing involved with any changes takes many iterations and potential rebuilds throughout the life cycle. These changes present themselves in many different aspects, from different EMR applications, system integrations, interface engineering, testing, validation, implementation, and also support. All of these require different specialties and certifications, skills, and most importantly, real-world knowledge. These are areas that we'll go through more in depth later, but I just wanted to briefly illustrate how many moving parts that must be accurate are involved. Now, across the healthcare EMR landscape, there are various commonalities across all systems. In very basic terms, all EMRs have a few areas that are fundamentally including, but not just limited to these. So your clinical functionality, which includes different solutions in their suite that cover the gamut of a clinical stay in either the inpatient or outpatient arena. Now, these are your normal clinical functions seen at any facility for the most part. All of these require specific skill sets and expertise. Your revenue cycle functionality are areas that include everything from registration to billing, patient movement, and all of those activities tied in during a clinical stay with the outcomes of the results, diagnoses, coding, and contractual requirements with insurance companies. The administrative functionality is becoming an area where optimization is paramount. The ability to cut down on manual interaction in both this area and the revenue cycle area will keep organizations working as efficiently as possible, creating potential major savings. As we can all imagine, these are needed at a time in all healthcare institutions' mind. Anytime that these automations or even optimization on current state workflows are changed, it will involve teams of experts to ensure everything is flowing appropriately and not causing unforeseen failures, not only within the EHR, but also in the downstream systems. So, what are electronic medical records and electronic health records? You will hear these terms, EMR and EHR, used interchangeably in most conversations with people in both the clinical and non-clinical spaces, but they're in fact a little bit different. Electronic medical records, or EMRs, are the patient records and charts within one practice or hospital, whereas electronic health records, or EHRs, contain those patients' records from multiple organizations in one view. For the purpose of this presentation, I will reference both terms, but overall, most systems today are built more with regards to multiple organizations. These systems are a vital part of healthcare IT and have become the focus of information sharing with other healthcare organizations such as your labs, specialists, imaging facilities, your pharmacies, clinics, and other financial and government institutions. In summary, EHRs are your patient-centric records that make information available in a secure manner to authorized users. And before the days of EHRs, your medical information was usually entered by hand or filling out paper charts. These paper chart structures have actually influenced the workflows and layouts in our EMRs today. And in the diagram to the right, you can see at a high level insight that all that is involved in a simple EMR. But as you saw on one of the first slides, there is much more to it. Let's talk through an outpatient hospital stay as a patient and where there are different solutions involved that need to be built and tested to ensure accuracy. For this example, you're just going in for a simple x-ray and some lab tests. Say you think you broke or sprained your wrist. We start at the top of the circle when you enter the hospital for any type of visit. You sit down in the registration booth and give demographic information and ask for your most updated version of your insurance. Then the registrar takes all that information and prints off a summary or does so digitally to get you to initial that the information's correct. Then they would print out your labels and armband. While you're there, the registrar would also scan in your insurance card and most likely your ID. Now, I know most of us have been through this, so I'm not going to go through all the details since we've all lived it. Now, but once you've gone ahead and read through your HIPAA and financial disclosure, you go ahead and sign, most likely electronically, understanding your rights. Then you can go ahead and pay with your bank card if you have a copay due. So let's stop there and think about some of the potential areas that need to be built and tested if any of those items in the workflow needed to be either upgraded, a change in vendors, or integrated with a new system. Analysts would be needed to be involved in build and testing along the way, dependent on which EHR the organization is currently using or which one they might be transitioning to. Systems analysts would also need to be involved in some of the build and testing due to the third-party systems involved, like your e-signature pads, your printers and scanners, and other peripheral devices, including individuals with expertise in each one of those different systems. Also, some organizations use auto-indexing for their labels in their medical record workflows using scanning. And this enables some automation, which, if broken, can then cause delays in your accounts receivables because you can't get a bill out the door in a timely manner if all of a sudden these automatic actions were having to be done manually. Then integration or interface analysts would need to be involved in the different integration points to ensure that any updates have not caused issues with the internal or downstream systems. Clinical analysts would need to be involved as well, to make sure, for instance, that the barcode scanning and medication administration works correctly on the armband, along with any other workflows in the system. Some point-of-care systems also scan the labels that are printed off, like your glucose monitors, which would obviously have to be tested as well. And lastly, in this portion, analysts with insurance eligibility understanding would need to ensure that the messages go to the clearinghouse correctly and are received properly back into the EHR to allow for electronic verification of your insurance eligibility. Along with that, all the correct copay, coinsurance, and other data points need to be accurate if the organization uses data pulls in their system. So then you're called back by the clinician, where they would take your vitals and observe your chart. This would give them an idea of your clinical history, which, if you were moving to a new system, would be something that they would have to be integrated into that new system. And this involves a myriad of the same analysts and experts discussed above, along with other system architects. I think you're starting to see the trend. So let's go ahead and continue around the cycle. You then get your X-ray and lab work done, which most likely sends some, if not all of the data to other systems for resulting of labs and reading of exams by professionals, which involve integration points and specialists around those systems, as all of those results need to post back accurately. This leads to certain diagnoses in your chart, along with treatment plans, which medicines you might be prescribed, among other things. Speeding this up for respect to time, this all leads with your visit ending with messages being sent to systems either internally within the EMR system or externally, so that all of your diagnosis related group information and coding info is sent out to systems, which most organizations use third-party computer assisted coding, and also to your payer for the amount of reimbursement that will be paid in the form of either an electronically submitted claim or other actions to make sure that the most accurate information is sent to those insurance companies. There are also intermediary claim scrubbing software and clearinghouse interaction. Now there's about a dozen more touch points that would have some form of build, testing, and validation involved with any changes in the system. Along with all of the above, you would need involvement with reporting teams to ensure that all of the data looks accurate in the potentially affected reports that organizations deem necessary. Then, any extracts that are sent out to third-party billers, as in the professional group of physicians that did the reading for your X-ray, need to be accurate as well. As you can see, your basic visit to the hospital for some diagnostic testing involves so many complexities that are happening in the background that most never think about. Organizations do not always have dedicated IT resources to handle these types of changes, or they need teams of people to come in and backfill while their dedicated IT teams are focused on such projects. Therefore, they regularly bring in teams with expertise in integration areas to manage the project from the top down. The health of the overall hospital system is tied to their financial well-being. So the importance to get such projects correct is paramount. Now, there are many benefits involved with EMRs for both patients and providers alike. There are also an array of other clinical and organizations benefits as well, but to be most effective, they need to be used correctly. The core of EMRs are about quality, safety, and efficiencies. And as great of tools as these are to providers and organizations, though, achieving the true benefits require transformation based on quality improvement methods, system and team-based care, while using evidence-based decision-making. Some of these key benefits include improvement in the accuracy of documentation and making diagnosis and claim submissions easier and more timely, automating alerts, noting potential risks, tracking and managing medications in one location, including drug interaction alerts, making preventative care easier to track and implement using those evidence-based decisions, which is important to healthcare facilities, especially with the changes we've seen in the recent years, including greater support in making point-of-care decisions, and streamlined workflows that help organizations work more efficiently, both from patient-facing situations to billing and all the activity between. Now, to put this into perspective, as little as a dozen or so years ago, if you had moved into a new area, your physician might not have the ability to pull up your historical records easily. This is now becoming less of an issue, which drastically can reduce potential errors in your chart. Your information is in 2 billing systems, clinical systems, lab systems, etc. when you moved, but now providers have the ability to see all of these things if you give them authorization to see your information. Whereas just in a short time ago, this was not common practice. This also brings the importance in the security around all of this data that is sitting out there, which is another area that organizations put a large quantity of time, effort, and finances in by investing both in-house and bringing outside firms in to ensure their data is secure at all points. This is information is a quick look at the evolution of EMRs and how the government incentives have helped form the usage of what is now common practice, especially over the last dozen or so years. The first EMRs were actually created in the 60s, and a couple of facilities implemented them into usage moving into the 70s, but these, of course, look nothing like what is used today. HL7 was a large standardization that is still used today in messages shared across institutions and systems, which is used behind the scenes, allowing healthcare systems to connect and share information. This has also spurred on legislation around sharing that information. Information sent using the HL7 standard is sent as a collection of one or more messages where each transmits one record or item of health-related information. Now, some examples of this include your patient records, your lab records, and your billing information. The HITECH Act was signed into law in 2009, which was part of an economic stimulus package that helped promote and expand the adoption of health information technology, specifically the uses of EHRs by healthcare providers. Prior to the introduction, only a fraction of hospitals had fully adopted EHRs. This act introduced incentives to encourage hospitals and other healthcare providers to make the changes by breaking down cost barriers with the usage of government finance. Meaningful use was another large push to encourage widespread EHR usage. Now, there were 4 stages in this implementation where certain criteria were laid out to meet for each stage with incentives tied to those stages. This also led to the 21st Century Cures Act that was signed in 2016 to help with definitions for interoperability and information blocking. With all of these incentives and implementations, healthcare IT is now on a steady march forward towards greater ease of information flow of patient data while still protecting its privacy and security. These building blocks have helped form what we see today in our current state, and future state trends continue to grow through our new landscape in the healthcare world. "2021 Forward" has the most of the focus on interoperability and increased focus on health information access for your patients, providers, and payers. This could help reduce the burden of certain administrative processes, such as your prior authorization with insurance companies needed for certain procedures. These regulations will help drive how information is exchanged between your payers, providers, and the patients. Also, since beginning of 2020 and the pandemic, there has been a huge advancement in the usage of video in telehealth area. Just a short period ago, this might not have been attainable, but out of necessity, which is the theme in many industries, especially healthcare, this has been sped up tremendously. This was helped with a three-phased approach that really caused the spike. One, we had increased consumer willingness to use telehealth. Two, there was an increased provider willingness to use telehealth. And three, there were regulatory changes enabling greater access and reimbursement. This usage has stabilized after the peak, but is still settled in at a claimed volume being approximately 38 times what they were prior to the pandemic. Also, proposed federal rules have been drafted around how hospitals are reimbursed for providing care. This could fundamentally change how healthcare organizations exchange data and report on the quality of care they provide. This touches on several areas in hospital operations, and also the health IT components could help improve how EHRs help inform public health agencies' activities, ensure patients receive safe and effective care, and automatically report that data to those authorities. Now, these changes could help modernize how hospitals share information through their electronic record systems so that doctors and nurses can provide the best care possible. This final version is slated to take effect around the start of 2022. Now, the COVID-19 pandemic highlighted the importance of rapid, accessible data to address public health crises and also the challenges that come from not having this data. In prior years, being able to send certain information to public health agencies electronically was optional for some hospitals and providers. These regulations would make it more of a requirement. This brings to light the motivators for change for the overall healthcare organization. They are usually slow adopters from my experience, where something like government mandates and or some form of tragedy is when transition seems to happen. Everyone's world has changed over the last couple of years. Organizations will need to focus on projects that help keep them on the cutting edge when it comes to technologies to help their operational outcomes. Here are some industry's top concerns, which I've seen firsthand. consumer adoption of telehealth, as we talked about, grew from around 11% during 2019 to approximately 46% in 2020. While these future implications of COVID-19 are still uncertain, it seems that telehealth adoption will continue to grow. Clinical trials are also changing to virtual in certain areas, which is a very large shift. Some of the top adopters in areas are areas of oncology, infectious disease, immunology, and women's health. Medical practices are also citing patient collections as one of their top revenue cycle management struggles, as patients are becoming responsible for larger portions of their medical bills. In order to help encourage patients to submit payments in a timely manner, providers must adhere to patient payment preferences. However, it's often challenging and costly for medical practices to set up such invoicing and payment processing systems in-house. Not only must they negotiate terms with each payment processor and build out the infrastructure, but they also must absorb the ongoing administrative costs of maintaining all of these such technologies. Additionally, healthcare providers are required to follow strict guidelines to protect their patient information. Another leading reason for consumers failing to pay their financial responsibility is confusion due to the lack of price transparency. In fact, as of January 1st, 2021, CMS implemented a new rule requiring hospitals to publish the prices they negotiate with insurers for various medical procedures. While some healthcare systems are opting to make their service prices accessible, which results in benefits like a reduction in patient confusion and surprise billing issues, most are still failing to comply. As of July 2021, a little over 5% of hospitals have fully complied with the mandate. Cybersecurity is always an area of concern with as much patient record information that is out there and with the continued push in sharing that information with internal and external institutions. Now, healthcare forecasting is difficult and uncertain for 2022 and beyond. A healthcare industry that has found itself fighting in the dark during the opening waves of the pandemic will need a forecasting system that provides a lens for the uncertainty ahead. Better sightlines can help healthcare companies prepare for shifts in the insurance market, economy, utilization, consumer behavior, and also future waves of infectious disease. For instance, in a response to an HRI survey in 2021, 74% of health executives said their organizations would need to invest more in predictive modeling in 2021 forward. Researchers stated that this capability to forecast the future is imperative for healthcare survival moving forward. Now, the challenges plaguing the medical product supply chain involve lack of geographic diversity, limited numbers of suppliers for essential medicines, inability to predict demand surges, and limited purchasing power of small and mid-sized health systems. This all existed before the COVID-19 pandemic, but they have been spotlighted by the crisis, as we've all seen and heard. The expectations moving forward are around distributors and health systems to consider establishing contracts with secondary suppliers, joining new groups, purchasing organizations, relocating facilities, and approaching storage and distribution on a more regional scale. So, what does all of this information mean? With projects necessary to be put in place to mitigate all of these concerns, companies are going to need teams that can come in with expertise and function at a high level. Sometimes this most likely is not in their operational budgets with the individuals that they have currently in-house. Teams will have to come in and hit the ground running and stick to tight timelines. Here are some healthcare trends that are ongoing, all which are the focus of executive leadership throughout organizations. The merger and acquisition activity within the healthcare industry shows no sign of slowing. Although the volume of deal activity declined slightly in the first quarter of 2021, the value of those deals increased to over $127 billion, which was a 40% increase over that same quarter. There was also continued significant investment by private equity firms in the physician practice sector, with such practices seeking financial stability and economies of scale to reduce their overall costs. Some drivers of these trends illustrated on the slide include that when the pandemic hit, healthcare organizations lost a large quantity of revenue in some of the areas with the largest profit, which are like your elective surgeries or other surgeries that were not deemed to be emergent in nature. As a bit of a multiplier on top of that, beds in emergency departments were being filled by COVID positive patients that may or may not have had insurance, or the insurance that those individuals had might not have had reimbursement rates that covered the costs of all the extra activities that were needed to care correctly for those patients. For an example, there was one healthcare organization that shut down elective surgery for a 4-month period during the beginning of the pandemic. They lost over $700 million in lost revenue during that same period. That, with limited payments on services that were necessary, you can see that optimization is a must to inject revenue back into all institutions, no matter the size. As with any industry, in the focus on machine learning and artificial intelligence, everyone has all of this data at their fingertips now. But how do they get it in an organized manner and make it useful for them to make fact-based predictions that will keep them ahead of the curve? Also, how can they ensure that this data is kept safe, especially in the healthcare industry, as critical and personal all of that information they have gathered is? This is where organizations will need help from reporting analysts, data scientists, and business intelligence specialists with expertise that they may or may not have in-house. Then, conversations around the safety of that data might bring up teams around data security analysts, security audits, and architects. There have been multiple security breaches in the news over the last couple of years, so there is a push to ensure companies continue to stay ahead of these groups that hold that data ransom. Based on my experience in the healthcare operational slide, these next couple of slides are specific areas that many organizations do not have the bandwidth to handle alongside their everyday activities with their current staff of full-time employees. These are areas that I see project-based resources can be utilized for positive business outcomes. We've talked about how large of a lift new implementations and mergers and acquisitions can be for healthcare institutions due to all the complexity and critical nature and all the intricacies involved both internally and downstream. Companies cannot risk the absence of experts taking a systematic, structured methodology to ensure their business operations do not suffer, whether it be in the revenue arena or worse yet, impact clinical operations and possibly cause harm to their patients. Focus on teams that can build, test, validate, and optimize workflows, along with overall management of all the activities and communication with operational leadership are important in any of these areas. One area that is not as clearly defined on the slide, that is an ongoing theme with any software company, are upgrades or releases that are done on, let's say, a quarterly or annual basis. This is true with all the EMR vendors as well, where there are consistent developments in certain areas or across the entire system that are pushed out to the user base. These have varying levels of complexity depending on how large the changes are. These sometimes require expertise and/or work effort that sometimes cannot be supported by current staff. I put these in the new implementation bucket, but these usually require full system testing, including downstream systems, to ensure that everything is mapped appropriately and that there are no negative outcomes of the system changes. As a continuation, here are some more areas of change that companies face on an ongoing basis. We have discussed government or payer-mandated changes, which are under consistent transformation. Therefore, there is fallout involved that is in a few of these items that organizations deal with on a regular basis. A couple of these areas this can be seen in are around reporting needs and changes to mandates in which public organizations receive information. When we talked about upgrades and new implementations, there are major rebuilds that sometimes need to be done to training environments. Most organizations, from what I have seen, do not do this regularly, so that when they do, their training environments and they need to be upgraded, it is a rather large lift where outside help is often needed. Many healthcare companies are also in the act of moving their EHR or other portions of their workloads and IT resources to the cloud. This can potentially enable faster pace of innovation and fully using the computational power for peak usage times and the use of mature machine learning frameworks. This ties back into the surge in AI and ML usage that is being seen across all industries. The last item that I wanted to key in on are ERP changes. Enterprise resource planning systems help integrate business processes across finance, HR, procurement, distribution, and other departments. From much of our previous conversation today, I think most of you can see where these areas integrate with organizations' EMR, as healthcare organizations spend a large amount of finances on everything from supplies to equipment, to name a few. These systems working together help companies optimize not only by reducing costs with quality procurement suppliers, but also get a good look into financials, which many are driven from charging in other areas within the EMR, including general ledger strings. The combination of these tools can help figure out, for example, what is the average cost per patient, how much you're spending on them, which areas are most profitable, along with many other analytics. So you can imagine it is quite the lift for any size healthcare firm when the decision is made to change vendors for their ERP system. To round out this presentation, we'll focus on some of the different job roles that can be potentially required for all of the topics we've discussed previously. As to note, at a high level here, you can see that there are analysts that will be application specific and might have different names depending on what EMR vendor the organization uses. These analysts can be on the business side or more clinical in nature, but most have specific areas they have in their purview. Now, most vendors have specific implementation specialists that are in-house, but from my experience, they bring very little outside experience into the conversation, which lends the need to bring in established, experienced help that has been through multiple implementations with different organizations. This helps get the most out of their teams pulled into any conversation, as they understand how different hospital or physician institutions do things and not just go by a stringent playbook. This gives more of a collaboration type of partnership, where if something does not work for the client, then these more seasoned analysts or specialists have the confidence to push back on the vendor with fact-based discussion. This helps IT and organizational leadership see the most benefits and opportunities available to them with any new workflows or systems. So I want to thank you all for your time today, and hopefully everyone has at least a few items that have stuck out that could be helpful in areas through previous experiences or conversations you've been involved in. Starting to come up with ideas and strategy to break into these areas using the tools and knowledge that we've gathered over the years can potentially bring many efficiencies and overall better patient care into our everyday lives. Please feel free to reach out to me with any questions that might come up, as I know there was a lot of information covered today. Thanks again for your time, and I look forward to speaking with you more in the healthcare IT and EHR space in the near future.